My name is Edgar Samaniego. I'm from the University of Iowa. I'm an interventional neurologist. Our center is the only comprehensive stroke center in the state of Iowa, and we have on average 1,300 stroke admissions a year and approximately 180 mechanical thrombectomies a year. Having such a large volume of mechanical thrombectomies, we're looking always for the best tools for performing these procedures. We have had access to the CEREGLIDE access catheter. This is a new technology provided by Cerenovus. It's an intermediate catheter that is also used for aspiration, and we have been using CEREGLIDE as an early release program. This is a 39-year-old woman with a right hemiparesis and NIH stroke scale of 12. On CTA, we can see that she has a left middle cerebral artery occlusion and also a large territory of tissue at risk with hypoperfusion. This is the pre-thrombectomy diagnostic angiogram where you can see the presence of an occlusion on the distal left middle cerebral artery. And on this case, I used to go with the intermediate catheter with minimal support, and we can see how I was able to navigate the intermediate catheter from the Petro segment into the MCA. The vascular result was excellent. We achieved recanalization TK3 with one pass. This is another case that I would like to share. Is an 88-year-old woman with left hemiparesis, facial droop, at high NIH of 17. In this case, again, you can see on the CT angiogram the occlusion of the distal middle cerebral artery. I really like this video and this case because her trajectory was very challenging to navigate. And we can see here how we're using the EMBOGAR, which is a balloon guide catheter. We inflate the balloon and the balloon inflated stays in the distal right common coronary artery. And with this help and inflating the balloon, what we're able to do is navigate the CEREGLIDE, just the CEREGLIDE by itself with some help of the O35 guide wire. And you see how the CEREGLIDE keeps going up without too much support, leading a little bit with the O35 guide wire into the proximal cervical ICA. Then as we keep going up, the CEREGLIDE keeps navigating. This tortuous anatomy is very trackable. And you can see how the CEREGLIDE accesses the distal supraclinoid ICA. In this case, we use a microwire and a microcatheter to reach to the MCA. You can see the excellent result. This is the pre-thrombectomy diagnostic serial angiogram. This is a lateral view, and you can see after the vascular territory is recanalized. These are the lateral and AP views. Great result, one pass, TK3, and a very short first pass from skin to puncture. We also have been happily surprised how the CEREGLIDE performs in the posterior circulation. This is a little bit difficult and more tortuous vascular territory because of the trajectory of the vertebral arteries. In this case, younger patient, 48-year-old woman with an NIH of 14. You can see on the CT angiogram there is an occlusion of the vascular in the distal vascular artery. This is the pre-thrombectomy. And here you can see the pre- and post-thrombectomy angiograms. Skin puncture was early, first pass was early, and a TK3 with one pass. So really nice how the CEREGLIDE performed and navigated the B4 segment and the tortuous anatomy of the vertebral arteries. This patient also had a concurrent occlusion of the ICA. You can see the CEREGLIDE 71, how nicely it navigated. This is, again, an unsubtracted angiogram. Usually what I do, I don't provide a lot of support to the intermediate catheter. I have the O35 wire behind the intermediate catheter. You see how it takes this sharp turn of the cavernous and ophthalmic segments of the ICA. And in this case, we achieve an excellent reperfusion. So my favorite characteristics of this new device are, first, is very trackable. I really like how it performs with tortuous anatomy. I usually do my cases with minimal support. and I find that CEREGLIDE provides really good navigability, and I usually access the target lesion with minimal support. The second quality that I like is the tip of the CEREGLIDE is very durable. Sometimes when contact aspiration doesn't work, I default to the use of a stent retriever. With some catheters, we have seen that the tip deforms after 2 or 3 passes with a stent retriever. I haven't seen that with CEREGLIDE. And the third feature that I really like is it does not cause any vasospasm. I haven't seen any dissection. In all the cases that I have used CEREGLIDE with minimal support, I have seen that there is no issue with injury to the target artery. Everything in a mechanical thrombectomy is measured in how effective you can take out the clot. We're talking about patients with really bad strokes, very symptomatic. So one of the metrics, for example, that we have is first pass effect. Any tool that is going to improve the first pass effect is very welcome into the field. CEREGLIDE definitely has a very high first pass effect in my experience, in my hands. The other thing that we have seen is number of passes. It can decrease the number of passes with using this technology. If you are to start doing more than 3 passes, 4, 5, 6 passes, you're already losing time, and there's also a high risk of complications. So with those 2 metrics, first pass effect and number of passes, CEREGLIDE has done really well. I definitely will recommend to give it a try. I know sometimes we have a lot of options. We have been fortunate in the field of mechanical thrombectomy and endovascular treatments to have access to a lot of new toys, new devices. I think this is one that's definitely worth the try. I have been pleased how CEREGLIDE performs, and I would recommend to my colleagues to give it a try and use it in the next acute ischemic stroke case that they're going to be treating.